Hello, my name is Kyle Allred, producer and co-founder of MedCram, and we have a special guest today, Dr. Michael Mina from the Harvard T.H. Chan School of Public Health, and he's a core member of the Center for Communicable Disease Dynamics. He's also an assistant professor of immunology and infectious diseases at the Harvard School of Public Health. He's an associate medical director in clinical microbiology, specifically molecular diagnostics in the Department of Pathology at Brigham and Women's Hospital at Harvard Medical School. And Dr. Mina has done extensive research on measles, vaccines. We put a link to his bio in the live stream description below, so take a look if you want to read more about his bio. Many of you who have been following our MedCram updates know Dr. Mina from our Update 98, where we dedicated the whole episode to featuring his work and research around really a different paradigm for COVID-19 testing in the United States and perhaps abroad. We're really excited about his ideas. We think this could be the path forward that we need to more safely open schools, open the economy. And we've spent the last couple weeks gathering your questions. We've received a lot of questions. Thank you for your comments and questions. And so we have about a half hour today with Dr. Mina to follow up on some of your questions, hear more about inexpensive testing options for COVID-19 that may be less sensitive than the gold standard PCR testing. But as you'll learn or have learned in our previous episode or other places where you've seen Dr. Mina's work, they're likely sensitive to pick up the vast majority of actually infectious COVID-19 cases. And that's really what we care about. So with that, I'd like to bring on Dr. Mina to the show. Dr. Mina, welcome. Thanks for joining us.
Thanks very much. It's really great to be here.
And I want to start with a question from my the other co-founder with MedCram, Dr. Roger Schwelt. He couldn't be here today because he is finally taking a vacation. But I actually want to start with a quote that I'll read from you. And this was, I think, published just a couple days ago in Harvard Magazine. So I'll read this quote and then I'll follow it up with a question here. So the U.S. government has spent billions of dollars supporting attempts to develop vaccines and therapeutics. And quote from Dr. Mina here, developing a good vaccine is very difficult to do. It's a crapshoot that may or may not work. We're putting billions more into developing therapeutics, treatments for COVID-19, which is really, really difficult. With rapid testing, by contrast, we have solutions sitting right in front of us right now that are cheaper, would be much quicker to build, and much less risky to actually introduce and roll out. And the only thing standing in the way is that there just doesn't seem to be the will to bring a public health tool to market. And I'll follow that up with a question here from Dr. Schwelt. What is the biggest barrier right now to making this testing a reality on a large scale?
Yeah, it's a great question. I think that the biggest barrier is not technological at this point. There are companies who are pretty close to having a product, but I think my point with that quote is really that you read is really that given the same level of resources that are going into developing vaccines, going into developing therapeutics, if that level of resources were put into honing in, really optimizing these rapid, daily, cheap paper strip type tests that everyone could potentially take every single day to detect if they're transmitting virus, there is no real technical barrier at all that would prevent them from being produced and developed. The major thing, unfortunately, is regulatory. These are tests that live in this gray zone of they give results back to individuals, which by definition, if an individual is going to get a biometric result about their health that's going to potentially cause them to change their behavior, that is more or less defined by CMS and CLIA as a test that falls under CLIA, which immediately puts it under FDA. Problem is the FDA is not a public health agency. They are an agency that is that one of their tasks is to evaluate and approve diagnostic tests. So they literally don't have a pathway to evaluate a test whose real major purpose is to reduce transmission of infections at a population level. So it's unfortunate that there doesn't seem to be this will to figure out a new way to do it. It just keeps living in this gray zone of it's not a public health tool because it gives results, but it is a public health tool because that's what you're saying it is, and where does it actually fit? And the real issue is that until it gets clearly defined who is going to regulate it, no companies that have products that are potentially available are going to go and manufacture these in the millions. There's no market because currently, if they did, the company would get shut down for illegal practices. Essentially by pumping out millions of tests that are not FDA approved would probably not fly. So the companies that could develop these tests right now won't for regulatory reasons, and the companies that are saying, okay, we'll go by the regulatory book and try to do this, they don't have a test that is going to necessarily pass muster as a diagnostic test. And again, we don't want these as diagnostic tests. We really want them as public health interventions that can serve to practically, in a couple of weeks, rapidly transform epidemics and diminish them. And so that, I think, is really, unfortunately, I wish I could say that it was some major technical hurdle that needs to get through, but it's not. It's this human problems that just need to be worked out politically.
Taking a step back, I want to bring up a quick chart that I put together on just comparing some of the advantages of a cheap antigen test versus the PCR test that's used the vast majority of the time in the United States. Could you talk a little bit about that for viewers that are tuning in today that are brand new to your work and this idea, and maybe they've heard, hey, these inexpensive antigen tests I've heard they're not very sensitive. Could you talk about some of the pros and cons, if you will? Maybe it's mostly pros to inexpensive antigen testing.
Yeah, absolutely. So I've been trying to rethink the words that I use, because I think saying that these are not sensitive completely misses the point. Actually, they can be used. They're much, much, much more sensitive than current PCR tests to detect people who are infectious. So a PCR test, if we could reasonably give everyone a PCR test every single day and get results back to them in 15 minutes, sure, go with the PCR test if that was a reality that we could live in. But it's just not. So the next best thing is we have to compare these sort of rapid tests that at the molecular level, they might be, let's say, 1,000 times less sensitive than PCR. And so that sounds scary. Why would you want a test that's 1,000 times less sensitive than PCR to detect molecules? The important thing to recognize is to really make sense of this, we have to think of the biology that underpins these infections and the biology of what happens with the virus when it grows inside of you. The virus starts at anywhere around, let's say 10 viral particles per milliliter, per swab that somebody gets. That's where it will start growing, and then by the time it gets to about 1,000 particles per swab, the PCR test, the really good sensitive PCR tests that are expensive and hard to get, they will start to detect the virus at around, let's say, 1,000. But the important thing is these rapid tests might not detect a signal until the virus gets to, say, 100,000. So for most people, they would think, oh, well, that's not good. I would rather the test that detects at 1,000 instead of 100,000. But actually, the important thing here is to know that most people, when they're transmitting this virus, their viral loads, by the time they're transmitting, are up at 1 million or 1 billion, or even for some people, 1 trillion. And so, the one way to think of this is, because thinking about viral loads is a little bit difficult for people who aren't used to it. One way to think of the difference is if I said, I'm interested in detecting millionaires, then I'm not going to go out into the world and look for every bank account that has $100 or $1,000 in it. That's going to do me no good. I only want to detect millionaires if I'm fundraising for a campaign or something. A different way to look at it is what we currently are saying. If you're a fire brigade and your goal is to make sure that you're putting out every single fire every single house fire that's happening in a city, you don't want to be distracted by every time somebody lights a match. You don't want to have to send a fire truck to that house just because somebody lit a candle in their home. But that's essentially the difference right now. We are saying that we want, in the world of PCR and viral testing, we're saying we can liken the type of test that PCR is to a fire truck going and finding every house that lights a match. And that is just a waste of resources. And it's going to completely take away from our ability to actually be able to detect the important cases. And so in this case, these rapid tests are they'll kind of be a filter to only be able to view the house fires. In this case, the people who are actually transmitting infections. And the good thing is that they'll tell you at the time that you take it whether you're transmitting. And that will allow you to make decisions that will tell you, okay, I don't want to go to school today. I don't want to go to work today. I don't want to go into this restaurant. And so it will start to very rapidly stop the transmission chains. So we don't have to go find everyone who has any virus signal in their nose at all. We just need to find the people who at this moment in time are at greatest risk for transmitting pathogens. And this is where I think that we really have to be considering the frequency of testing becomes so much more important than the sensitivity. Because if somebody's taking a test every single day, the virus, by the time it passes 100,000, you'll detect it on that day. Mm-hmm. You don't have to, versus if you're just using a PCR test every 3 weeks, you know, that you're very likely to miss whole infections since most of them are asymptomatic.
You mentioned earlier that the FDA is a real barrier in this, and there's not a clear way to get these tests approved at this time. We had a question come in from Joel, and I'll read it here. The FDA on Wednesday, July 29th, issued a new emergency use authorization template for developing over-the-counter COVID-19 diagnostic tests that can be used outside of a laboratory. The update comes as the agency and other government agencies push to increase testing for SARS-CoV-2 in the United States. When the non-prescription tests become available, the agency hopes to see them used at locations like offices and schools in addition to at home. Is this a positive move related to this Dr. Michael Mina discussion?
Yeah, it's a great question and one that continues to come up. I think in some ways I would say it's one step forward and in a sort of a strange way a couple of steps backwards. So the step forward is absolutely a good one, and it is that the FDA has clearly laid out that they are willing to have tests that can be performed at home and at offices and by individuals. Where it doesn't go far enough, and almost they've kind of put their cards down on the table now to show what they are going to be expecting from these. And what they are expecting, unfortunately, is pretty much an at-home test that's going to meet all of the same metrics and milestones as a solid laboratory-based test. The molecular sensitivity, they still want to be 90% that of PCR. And so this causes problems. If your molecular sensitivity has to be 90% that of PCR, you're not going to achieve this daily rapid test. They also want every test to sort of have a mechanism so that every negative and every positive test can be reported to the Department of Health. So this means that all of these, what could be $1 paper strips, need to be somehow linked to the internet or something along those lines for reporting. So then it means that every one of these companies who's developing these nice little cheap biological paper strips has to become a software company or have some other option for reporting. And we can't realistically create a test that is very likely to ensure that everyone is going to report their negative results every single day to the Department of Health. That's just unlikely to happen. So there would have to be some sort of trigger built into the test, which immediately is going to create it to be more of a more expensive test. And so I think of rapid daily tests in two camps. On the one hand, and well, I like coffee, and espresso. So you have the Nespresso camp, and these are going to be machines that you have to go out and buy, and you have to buy capsules that are proprietary to that instrument. And yeah, they could probably be connected to the web, and but they're a big machine, and that is immediately going to limit its distribution and utility. But it will probably do the job and do a really good job, relatively speaking. Um, I actually like to make my own espresso, but Nespresso is good enough. But what I really want to see for these tests is not an espresso model. That's good if we can get them cheap, but I just don't believe we can get them cheap and distributed in the tens or hundreds of millions. I want the instant coffee version that every single person around the world can easily get, that they have, that are cheap, that there's no frills, they're not connected to the internet, there's no buttons. It's just but it does the job. And the job in this case is to tell you if you're detected as positive. And so both of these things can exist today, but the FDA is really pushing for this model over here, the Nespresso model. And I think that given the extreme need for these, I just think it's losing track of what the real importance here is. And I'll just take this moment to really drive the importance issue home, and that is there is no more important, I think, more important intervention that can be really that is in the works right now, besides a vaccine, and besides a very effective vaccine than this. This is a tool that's sitting in front of us right now that the government and the feds and everyone should be putting billions of dollars into ensuring that every person has one of these tests in their home, and recognizing that this is a way forward, that we pretty much have a different way to create, if you will, herd immunity, to stop community transmission in the absence of a vaccine, and it's sitting in front of us, and it's cheap and easy. But there's just no will, I think. But this is probably the most important potential tool that could exist today.
I love that coffee analogy, because the cheap coffee still has plenty of caffeine in it. It still does its job.
It's exactly right. And in fact, it probably has more caffeine a lot of times. And I do think that, the frequency that you use it, you could drink 18 cups of cheap instant coffee a day for relatively no price, and you'll end up getting more caffeine than you would if you drink 1 cup of Nespresso.
Okay, speaking of the FDA and some barriers, here is a question from Gustav. Said, thank you very much for publicizing these results. The issue of practicality versus ideal specificity is not in the textbooks. Implementation may require a philosophical reorientation of the epidemiological community. Are they capable of that big of a leap? Is the FDA capable?
Again, I've been a little bit harsh on the FDA, but I think so. I want to not be quite so harsh, and I want to say this, that I actually think that the FDA, their mandate is to evaluate diagnostics. They were never given a mandate, as far as I know, to evaluate public health tools. So I think it's a little bit, unfortunately, it's maybe going to be CMS and CLIA that need to reevaluate where these tests sit. I mean, the short answer at the moment is no. I don't think that our current situation or our current infrastructure is set up to have a philosophical repositioning. That said, I do think that in part because of the videos that you all made of the TWIV interview, has really, these things have gone a little bit viral. We've been really pushing it through op-eds and through scientific research to show that it can work. And I think there's beginning to become a groundswell of support at all levels And I know for a fact that the message has gotten across to all levels of individuals who would potentially be making the big decisions. So I think if there continues to be sort of political pressure and scientific pressure and public pressure to not say that we are okay uh, lowering our bar and wanting an inferior diagnostic test, but to say we want a public health tool that can change the course of this epidemic, and this is what it looks like. I think that it can change. It's an uphill battle for sure. It's going to require political will. It's going to require financial will. But I think through things like this that we will probably get there. I just hope it's really soon because people are continuing to die every single day, and it's like it feels in large part like the governing agencies are seeing this. I know that this isn't how they're feeling, but that it's like they're playing the game of just this is right, this is wrong, and meanwhile the house is on fire, and nobody's treating it like with the urgency and like the emergency that it truly is. We are now playing the same rules that we always play by, which just clearly is failing.
Mm. Speaking of that, I think I heard you on a different interview talk about how, to your point, you've been able to get a line into people in Congress, some governors, people connected to the White House. In light of all this, in light of, as you described, the House is on fire to some degree. What's been their response? Are any of these our elected officials kind of sensing the urgency of this?
So I've been very pleasantly surprised at what many elected officials are the urgency and the sense of urgency that they're conveying to me. Senators, congresspeople, mayors, and some governors have all gotten in touch. And so I do think that there is a growing sense of urgency. I don't think many of them don't understand the complexities of the landscape at the federal level that they're dealing with or contending with. Of course, those at the federal level do, and it's there that I think we're having we're seeing the biggest lack of urgency. And I think part of it is some bit of, who wants to be liable for these types of things if it turns out not to work. Nobody wants to say that they were the ones to approve a test to go out into the public domain that wasn't as good as the gold standard. I have very little concern about that, but I think from the regulatory bodies, some of the people that really do need to be making who are empowered to make these big decisions about how to restructure this whole discussion. At least on the surface, we're seeing the least amount of urgency from them, and they're kind of saying, "Oh, well, this is submit your request or your application through this portal, and we'll get back to you in 3 months or whatever it might be," And that's really extraordinarily frustrating, and it is why we are making inroads with mayors and governors and senators, because they might at least have the potential to influence this. And if nothing else, I think that there is a role for states to leverage states' rights over federal to try to push this at least on a state-by-state basis.
The number one question that we received over the past couple of weeks, I'll pull an example of it up. Miguel here states it pretty well. He says, "So who is producing these tests? Company name, brands, where to find them?"
Sure. So there's not a lot, and this is part of my frustration with the federal government with this. People keep asking who's producing them, and I'll get to that because there is production happening, or at least there's assays that have been developed. But in my opinion, this is such a simple idea and such a simple that these tests have existed for other pathogens for many years. We shouldn't be asking the question of what companies can produce these and how many can they produce. We should be asking the question, who has the federal government hired to directly start developing and producing these in the millions. This should not be something, the companies that are producing them, the really simple paper strip tests, there's one company in Boston called E25 Bio. They are literally a company of 3 people. And they are one of the closest to having a truly workable, they do have a workable model. It just needs to be evaluated, and at the moment it's not going, it's maybe not ready to pass through all these FDA hurdles if it needs to be approved as a diagnostic tool. But this is a company of 3 people, and this is a solution that could completely change the whole course of this epidemic, short of a vaccine. There's also, I'm aware that 3M is building a test, and that is in collaboration with some folks at MIT. And then there are a number of other companies that are building more of a stripped down version of the Nespresso model. And these are like Mammoth Biosciences is producing one. Oh, also Sherlock Bioscience is also producing a potential paper strip. So these companies are all in slightly different phases of their production. But one of the points that I want to get across is we continue to just treat this as though business as usual. We're going to bank on our normal free market capitalistic enterprise and hope that some company rises up with end these massive outbreaks in the United States. But these aren't companies like Merck and Glaxo and Pfizer. These are small startups by and large, and the government should be, whatever they need to do. If it means that they buy the companies or they temporarily take over and they use their IP and pump billions of dollars into the development of these tests, hopefully in the long term we'll have a massive payoff for the companies. Whatever it needs to be, at the end of the day, we shouldn't be asking who's actually developing them now, because these are small little companies, and they do have the potential, though. E25 Bio, for example, I believe, I don't work for them, I make no money from any of these companies. I believe that E25 Bio, for example, maybe could produce a few million in a week or something, or they have manufacturers lined up that could potentially do that kind of thing, and the prices could be very low. My imagination suggests to me that 3M is a huge company. We know that they are building tests, and I presume that they would be able to make quite a lot of these as well. So there are some companies that could do it. It's just none of them are taking that next leap to actually start manufacturing them, because there's no legal route to do it. They don't want to get shut down. And because there's no legal route to do it, there's no purchasers. So it's a horrible catch-22 everyone's in.
When I was preparing for this, I kind of scoured the internet trying to figure out which companies are making headway, which projects are making headway. It's kind of difficult to find, even though this has been in the news more and more. And so I want to ask you about some of these specifically that are in development. You mentioned the MIT 3M collaboration. And then there's Bectron, Dixon and Company, and Quidel, which both got this EUA approval. But the disheartening thing is that these require a small machine to use, from my understanding, and so they're not really set up for home testing like you're advocating for. Is that correct with those companies that have already gotten the EUA?
That's correct, and this is so I think this is. There's a lot of confusion around this between the EUA template that came out. Everyone said, hurrah, the FDA is making the right choice. And then just yesterday, or I believe it was yesterday, 6 governors of 6 states, including Massachusetts, headed by Maryland, I believe, came out with a pretty ambitious, relatively speaking, of an ambitious proposal, and so that they are going to band together and purchase 3 million of these BD, Becton Dickinson, or Quidel antigen tests, 500,000 per state, to put out into the community. But as you say, these all need, it's one thing to buy 500,000 tests or 3 million tests, but they all have to get processed on a little machine. And it's those machines that become limiting. And unfortunately, these tests are true diagnostic tests, so that makes them more expensive. And that means that they do have to report because they are being regulated by CLIA. They're not public health tools, they're diagnostic. And so who can use the test is going to be limited. It's going to be limited probably to people who are highly trained to use this particular instruments, as simple as they are. And then the instruments themselves are going to be limited in terms of where they can be placed. And then because they are tests that are reimbursable by insurance companies, that immediately inflates the sale price of each of these individual tests that are used for the instrument. So everything about it is, this story is just a continuation of this effort to try to fit diagnostic tests, which are a square peg into, or a round peg or whatever it is, into a square hole of public health testing. Yeah. And we just need to start to separate them and say that these are different classes of tests. We don't want to buy diagnostic tests for population level control of an infection. It's just the wrong avenue. But the governors are looking forward and they're saying, well, this is what we got now. So that's what they're going with. But like you said, these are different, these BD and the Quidel instruments, they're good instruments, but they're not the right ones for this purpose.
And from my understanding, those are still highly sensitive. I mean, they got that FDA EUA, so yeah, and the expense really gets driven up when you try to achieve that sensitivity.
That's right. They need the instrument because essentially they're based on similar technologies. The difference here is if you have this instrument to like really closely read what happens on the little paper strip, essentially the paper strip's in a little cartridge, and you put the cartridge into a sensor, and it can scan it essentially, and it does a better job than, for example, the human eye could to really be able to read it. Now, one thing, maybe a nice compromise if a company comes out with it would be to use a phone. Maybe, most people have a phone, but it still does limit it. If you could have the phone scan the thing in some sort of cheap plastic thing that you throw into your camera, maybe there would be a solution there. And I know that some companies might be thinking about those ideas, but it still limits, I would say, the overall intended use, which is to get this out to millions and millions of people, soon.
Yeah. I want to ask you about a couple of these other collaborations or projects. You mentioned the Sherlock Bioscience WIS Institute at Harvard, and could you talk about the technology of that? I mean, that's a little bit different technology. From my understanding, that's CRISPR based, right?
That's right. And so they're pioneering different uses of CRISPR instead of just having. So most of these antigen tests we're talking about have an antibody, not a human antibody. So this isn't a serology test or an antibody test, but they use an antibody that's embedded on the little filter paper to catch the virus as it flows across on a sample. If this was a little paper strip, as the swab sample kind of flows across a little piece of paper through capillary action, for example, if there's virus on it, the antibodies embedded in a strip of it will capture the antigen. And that's kind of how a lot of these, what we call lateral flow assays, work. Pregnancy tests are similar, for example, a little different, but pretty similar. And the CRISPR-based technology is a different approach. And it's, instead of having a monoclonal antibody there, you actually have sort of a CRISPR-Cas probe that is the same kind of thing that we use for CRISPR in a laboratory, but you could potentially embed some of these reagents. And so instead of looking for a protein on the virus, it actually does look for the genetic material of the virus. And so usually it will require one extra step, which you might have to lyse and degrade the virus so that the nucleotides get released and exposed to the environment. So it adds one additional potential barrier. But I think that if Sherlock can really push this technology forward to take CRISPR technology and get it embedded onto a paper strip type of technology and really have some sort of detection signal that does a good job at lighting up a line on the paper or something, then they can really get it. And they have a product that is not for sale or anything. It's still in development, but it's getting there. And I think that they too will have, if it gets there, I think it will also be very cheap and would, it's unclear if it will be more sensitive or not than some of these other antigen tests. My expectation, though, is that it has the potential to be more sensitive.
And the potential to be as cheap as these paper antigen tests?
Yeah, absolutely. I think so. And I feel less confident saying that, though, because I haven't really seen what the real cost will be, what the stability of the reagents will be, what the supply chain will look like. Right. It's a little bit more unknown, but I think that theoretically they can be as cheap.
I want to ask you about this $1.5 billion Radix, and from my understanding, they're partnered with the NIH to develop kind of a Shark Tank-like competition for new rapid diagnostics. And my question is, do you think this is the approach they ought to be taking? You mentioned earlier maybe a more collaborative approach would be the way to go. So any thoughts you have on that?
Yeah, this is great. You're really hitting on all the points that I think are confusing people, or at least all the big points that are confusing. So the Radix program, I think, is from an NIH perspective, I think is a really was a great idea and is a great idea still. It is a different idea, though. It's really to scale up. It was an idea to create a Shark Tank approach to have different assay manufacturers and laboratories compete to create more high throughput, high capacity tests, but still all within this idea of diagnostic tests. And so it wasn't really to create these kind of paper strip tests. All of the companies that were funded, 4 of them received money, to quite a lot of money, to really build up their laboratory-based capacity. So that's great, but I think, and then 3 of them or 2 or 3, I forget, are point of care diagnostics, but similar to the BD and the Quidel, which I just talked about, which need instruments still. I think there's one that requires a little bit lighter weight of an instrument, and I'm just forgetting the name of it right now, but it has some more potential than the other 2 to really scale up. But still, they're all diagnostic in nature. My estimation is that even with the best case scenario, if all of those are wildly successful, maybe they will increase the testing capacity of our country 50%. To put that in perspective, I don't want to see the testing capacity in this country increase 50% or even 100%. 100% would be 2x. I want to see it increase 100x. So we're not doing 800,000 tests every day. I want to see us, doing somewhere on the order of 50 to 100 million tests, every couple of days. And we're not anywhere close to that. So we really need to be scaling up on tens of fold, not percentages.
This is a question I had as well after seeing your great interview on This Week in Virology, which is where we first became familiar with your work. And it's from Jeff, and he says, the This Week in Virology interview with Dr. Mina and Dr. Schweltz Update 98 described the NYU study of the Abbott ID Now test. He said, but this is not an inexpensive home test, which of course you're aware of, Dr. Mina, but you use that as an example of a test that has a little bit less sensitivity, but it's still good enough sensitivity to detect the vast majority of infectious COVID-19. So Jeff's question goes on to say, for the paper strip tests, these antigen tests, what are the sensitivity and specificity figures of those, and how do they compare with like the Abbott ID Now test?
Mm-hmm. Yeah, so to just really clarify, and I feel like I'm continuously having to clarify this Abbott ID Now instrument. It's actually, I would put it in the very, very high sensitivity, right up there with PCR. I'm guessing since this is MedCram, there's a lot of people who read literature, who read scientific literature and studies. The study that really that drove this message that the Abbott ID Now was not particularly sensitive compared to PCR was full of a lot of flaws in terms of the main outcome. And it's actually, so for anyone who understands CT values, if you remove in that study, the study was just really enriched with extraordinarily low CT values because they were comparing it against the Cepheid Expert Express, which is another one of these fairly rapid CLIA wave tests. But the Cepheid Expert Express is in many ways even better than the gold standard PCR. So it can detect extraordinarily low numbers. And in that study, they just had like half of all of the samples that were in the study were at CT values above 40, which is essentially, would be negative on all gold standard assays. Mm. So that if the Abbott was just a smidge less sensitive than the Gene Expert, it's going to miss all of these, even though the only ones it really missed were samples that any other test would usually call negative anyway. So in actuality, if you look at that study a little bit differently and a little more discerning, you look at the raw data from it. In that same study, it wasn't a 50% sensitivity; it was actually a 90 or 95% sensitivity. And so you just really have to dig into the data, which unfortunately wasn't published with it. But it is published in the preprint of that study. So I would suggest people go check out the preprint and look for yourself. To answer the question though, so the question, the Abbott is, again, it's sort of, I put it in one of these, it's really in like the super Nespresso machine. It's not cheap. It's really, really good. But it's not going to be scalable for public health use. It's a really good diagnostic. It gives rapid results, but different. And so to compare them, just the question of asking about the sensitivity is a hard one. I think when we talk about sensitivity, we have to stop comparing. We have to change a target of what it is we're looking for with sensitivity. Because right now, if you're comparing it against a molecular test like an Abbott or a PCR instrument, these look for a whole different biological substrate. They look for RNA. There's this whole period of time, which is, what you drew really, I presume it was you drawing it, what you drew really nicely on the other video is there's the viral load goes way up and then it comes way down. And this is based on RNA. The RNA persists for a very long period of time. So if you take any of these samples that are positive, 1 to 6 weeks after somebody has been infected, those people aren't transmitting virus. But they can remain RNA positive. So that means they'll remain positive on the Abbott test or on the PCR test for weeks. And any antigen test you process during that period of time is going to come up negative because there's no antigen left. There's no virus. It's just the RNA. And this is what I think is so important to understand. So we have to change the target and no longer be comparing it to what level of RNA is it actually able to detect to, what's the comparison between RNA and antigen. It's really maybe how many days, for example, maybe the target should be how many days of transmissibility does the in that sense, I would say that if we're thinking about days, I would say that the antigen test maybe loses 1 day compared to a PCR test. But that 1 day that it loses is on the upswing, and I would say people probably aren't even likely to transmit during that first day anyway. So it's extraordinarily small compared to in terms of what's the sensitivity. And I would say that if I were to take a guess, I would say the absolute sensitivity relative to PCR to capture people when they're transmitting in a given sample is probably 80 or 90% sensitive. But I would say that because you can use it daily, potentially, the PCR test used infrequently probably has a sensitivity of 5% to capture people. And the antigen test used daily has a sensitivity of maybe 80 or 90% to capture people. So the sensitivity, given the frequency, is much, much higher than PCR.
In a way, what I hear you saying, and correct me if this is wrong, is we should stop comparing a cheap antigen test, a paper test used for surveillance and meant to be used frequently, with the gold standard or even the Abbott ID Now test, which is an expensive, really accurate test. And we should just have a blank slate and say, let's start over with this and let's use cheap inexpensive test that people can use at home, like a pregnancy test, and in a way, kind of start over a bit. Is that is that kind of what I hear you saying?
Yeah, it is. And the other important thing with that is that we have to look at these tests. People, I always get the comment, something like, well, if they're not perfect, you're going to let somebody slip by who's transmitting virus, if they're not capturing 100% of people. My comment to that is right now we're not testing anyone. So everyone's slipping by,
Right.
And that's like the argument of saying that masks won't stop all transmission, so why wear a mask? Well, people are comfortable with the idea that masks give you partial protection. People are comfortable with the idea that seatbelts and airbags give you partial protection in a car accident if it happens. This is a way to give the individuals and businesses partial, but very good partial protection, maybe 80% or so. But the really important thing is that, so some people would say, oh, well, that 20% could wreak havoc in a business. If you have a super spreading event get by, you could, but the important thing is these will almost surely detect anyone who's a potential super spreader because they have so much more virus. So it'd be very hard for them to not work for a super spreader. But more so, because they are public health tests, what they will do the whole population, they will drop the prevalence of the virus in the whole population. And if you can get the whole population prevalence to go way down, then immediately the absolute risk to everyone goes way down. The chances of somebody carrying a virus into a school, even if that person's not testing at all, over here goes way down because this group of people no longer has the virus. So we really have to put on our public health hats when we're evaluating these and look at the big picture. And unfortunately, just because it's a public health tool that looks like a diagnostic test, I think people are having a hard time getting out of their diagnostic thinking.
Yeah. Speaking of that, I want to go to a question. I thought this was a good question that came in from Andy, and we received similar questions to this. Business owners, for example, saying, hey, can I get these tests for my employees? Can we make our workplace safer? And so Andy's question is, can the company sell the tests without FDA approval, like they do with supplements and vitamins?
So that's what we're trying to get. At the moment, no. And that's because, as I mentioned in the beginning, this is because these are tests that the current definition is that if there's a biological test that somebody could take and it will be likely to alter the decisions that person makes, then it immediately falls under a potentially CLIA-regulated test, and therefore
Sorry,
FDA.
Dr. Mina, for people that aren't familiar with CLIA, could you just say what that is?
Yeah, so CLIA stands for Clinical Laboratory Improvements Amendment, I believe. And this is CLIA is a designation under CMS, which essentially is the type of it. If you want to perform a clinical test, you have to have a CLIA you have to have a CLIA certificate. It's essentially a license to a laboratory to say you have all of the right protocols in place, you have the right standards, and your people are trained appropriately, that we approve you. You have a license to perform clinical laboratory tests. So any hospital lab, clinical lab in a doctor's office, these are all different CLIA-approved laboratories. LabCorp and Quest, these mega labs, these are CLIA-approved laboratories, and there's different classes of CLIA. There's sort of the majority of the PCR tests are performed in what we call high complexity designations of CLIA. But there's also low complexity, which would allow you to run something like a Quidel instrument or a BD Dickinson, really simple, or an Abbott ID Now instrument. So CLIA is sort of the arbiter of sort of who, if any clinical test that is performed in this country anyway, has to be performed either within a CLIA lab, a CLIA certified lab, or it needs to be CLIA waived, which means that the test is approved to be used outside of a CLIA laboratory. And that's what sort of the Cepheid and the Abbott ID Now and Quidel, they all went for CLIA waivers. So that allows you, but it doesn't mean that anyone off the street can go and buy it. You still have to have some sort of formality, and you have to be trained and designated before you can just go buy a CLIA waived test. So unfortunately, what it means is businesses at the moment can't purchase these tests because they all remain under the jurisdiction of CLIA, which, because they give a result back to an individual, that could potentially change that person's behavior. And that automatically means that they are under the jurisdiction of FDA approval as a diagnostic test. And this is absolutely the crux of the matter, which is we need a different pathway. We need a different designation that allows a result to be given to a person that could change their behavior, that is considered in the context of public health and not simply diagnostics.
Thank you for that. Let's see. I had a question here about the sample itself, and Ryan wanted to know. Well, it's a comment that I'm going to adapt to a question, and he says, since it's a saliva test, you could have the entire household spit into one sample and test the entire household together. Is that possible to pool these saliva tests as well?
It is, and I have advocated for it. We have a preprint that's all about pooling, and so currently is that most laboratories, there's been a lot of fanfare again by the FDA approving pool testing to go forward, and people got very excited because LabCorp was given the ability to pool 4 or 5 samples together. This does very little. When you're pooling the samples in the laboratory, it means you still have to collect all of the samples individually and go through actually an extra step of pooling them together. And it's very, very seldom is the true bottleneck in laboratory testing the actual laboratory assay performance itself. It's usually the upfront reading the barcodes, gathering the samples, organizing them, in this case, pooling. And then if you get a positive, you'd have to decouple that pool and test each one individually. So that's what's been approved. And so it actually gives very little efficiency gain overall. The only gain that it really gives is if the reagent itself is the limiting, like the primers or anything like that, is the limiting resource. What that person asked, though, I think is an exceptionally good piece of thought. And that is, what if we don't put the onus on the laboratory to test each positive, but we assume that people, or groups of people, can be tested all together? Because frankly, if I'm a parent and I have a kid who tests positive with COVID, regardless of what my test is, I probably shouldn't go to work for the next 10 days anyway, if not more. So it's a really great idea to take people who are clustered together and likely to transmit to each other, like households, and just pool all of their samples at once so that they are inextricably linked. And instead of 5 samples going to the lab gets just 1. Or if it's even just a paper strip, maybe you could figure out how to just do 1, and that would really allow you to conserve at-home tests. And so it's a great idea, I think, and one that we should really be exploring. It's, again, something that runs up against FDA because FDA wants any pool to be able to quickly be identified as which is the culprit. But this would, if you're putting the primary specimens all together, it precludes your ability to disentangle them.
Got a question here along those lines. Does the quality of the spit sample affect the results? For example, spit that comes from deep within the throat as opposed to spit saliva generated strictly from within the mouth. And then the other part of the question is, would spit generated from the throat have a better chance of testing positive at the higher CT values? And the last thing they said, sorry, kind of a long question here, is I wonder if poor spit quality is more responsible for the false negatives in the high 30s of CT value, relatively low viral load, rather than the test's sensitivity constraints?
The short answer is yes. And it's one of the problems with, so I want to clarify because there's been some confusion about this. The rapid paper strip tests don't have to use spit. They can also use a nasal swab dunked into some contact solution, just some saline solution in the tube. So it can be both. My bias is actually a little bit against the use of saliva versus an anterior, like a Q-tip that you just kind of rub against the front of your nose every day and dunk it into a little tube of saline. It could quite literally be a tube of contact solution, for example, potentially. And that's because the saliva itself, as the person asked, can be it can be different textures, it can be different consistencies, it can come from different niches of the oropharynx or respiratory tract or the mouth. And so in that sense, I would say that it does lead to some significant variability. That said, there are potentially like instruments that you could put right under your tongue, for example, to pull virus out in a slightly more consistent way each day. And different approaches. I would say that the jury's still out there in terms of what is the best approach for getting the best saliva type of specimen. And it seems pretty variable.
Mm-hmm. You have spoke about this question a bit, but I want to come back to this. Is how amenable are these paper tests to the massive upscaling required to make them a key component in track and trace or other frontline settings like hospitals, care homes, and airports? And again, I know you spoke about this a little bit, but do you think this paper antigen test, the technology is such that we can really scale this the way we need to?
I do. I think it much more than any of the other options that are on the table. These are tests that even a startup company partnering with a smaller manufacturer can make millions a week, and millions a week is essentially the limit of the major companies right now. And so yes, I think that the scale can be huge here. One of the beauties of this is, we talk about test and trace and things like that. One of the real beautiful things about this kind of test, at least from a public health perspective, is if everyone's doing these tests, you can almost get rid of contact tracing because everyone would essentially, you're getting cases, so you're breaking so many transmission chains early that if you go and infect somebody else, that they're most likely going to be testing anyway, which is all a contact tracer would do. Yeah. So if everyone has the test and everyone's testing, and so you don't, from a public health perspective, you don't have to use contact tracing as the way to identify potential other positive and at-risk individuals because everyone else has tests in their pocket that they can use. So it really changes the game. It changes everything about how we've been thinking about the approaches that we take to this epidemic. And that's because all of the approaches that we've taken so far are sort of based around the assumption that we couldn't be testing everyone daily, but we have an opportunity to be able to do that.
Another quick question. We got to let you go here soon, Dr. Mina. This is from a nurse, and it's kind of a long question, so I'll just abbreviate it to say, why are labs not required to report CT values with positive results if we now know to some degree infectious thresholds? And she goes on to describe how that could be really useful for skilled nursing facilities, for PPE conservation. Do you know why labs aren't required to report that information?
I know well. I run one of these labs, and so yes, they're not allowed to. It's not that they're not required to. It's that they're legally not allowed to report them in any standardized way. And we do it all the time. Labs do it all the time offline, if you will, where a physician calls up and they say, my patient's been positive twice. What were the CT values? And I've actually published one paper a couple of months ago in Clinical Infectious Diseases, CID, on this particular issue of that we really should be reporting the CT values. And this is a different issue. I have a whole sort of area that my lab works on now, which is all around how much more power there is in the CT values if we just made it available for public health, to contact tracers. The individual person who's infected may or may not be able to use it very much, but if you ask me, a CT value of 40, if your first diagnosis is made and you felt pretty good, and it was just on a screening test, and you have a CT value of, let's say, 37, well, at the moment, that's just going to show up to you as a plus. You're positive, and then you're going to have to go in quarantine for 10 or 14 days. But if we actually gave you your CT value and I said to you, look, your CT value is 37, there's a small chance that it happens to be a really low viral load and it's on the way up. And so it'd be really crucial to know that. But the vast majority of CT value samples that are caught at a CT value of 37 or a very low viral RNA copy number are going to be actually weeks past.
Oh,
am I still here?
Lost you for a moment. I think the last thing I heard was you said at the tail end of the infection, you're going to be likely, that's when you're likely going to pick up these really high CT values, low viral loads. And then I think I lost you.
Yeah, so that's exactly right. And so what I would suggest that we do is, which I think this person is intuiting, is that we specifically say what the CT value is, and every time there's a positive person is detected, you wait 24 hours and you test them again. If their CT value has gone from 37 to 20, you know that they need to be quarantining for 14 days. They're infectious. But if their CT value goes from 37 to 37 and doesn't change at all, you know that they are past their infectivity, and they probably, despite having just been diagnosed for the first time, it's too late, that you've already missed it, and they don't even need to quarantine at all. So it's actually, there's a whole efficiency gain for society here if we are currently quarantining millions of people for no reason. And if you look at the average CT value, just as an example, in Massachusetts right now, the average CT value is like 36 or 37. Even the interquartile range is all above 30. Wow. So that means almost every specimen, almost every person that we currently diagnose and ask to quarantine for 10 or 14 days right now in Massachusetts, and this is across the whole country, well, not in Georgia and Texas where infections are raging. There's a lot of people who are getting caught infectious there, but are generally being quarantined what I would call erroneously. They don't actually need to self-isolate and quarantine for 10 or 14 days. Unfortunately, we've already missed their positivity. And then we take it one step further to really push home the reason why we should be reporting out CT values, at the very least, to contact tracers. Anyone who has a CT value of 37 already doesn't need to be contacted. It's a waste of time for a contact tracer to go and trace them 2 days before they got their swab, because they probably were infectious 2 weeks before they got their swab. So you're contact tracing the wrong people and spending millions of dollars to do it. I could continue pointing out the flaws in our surveillance system, but it's why these are all really good questions, and they are the reasons why we are currently failing to control this virus, because we have all this regulation that stops these normal things that should be going on, like reporting out CT values.
Right. Well, we know you're doing everything you can with your research and with taking interviews like this one and being featured in articles. What can we do? What can our viewers do, whether they're a clinician or a non-medical person, to help move this along and continue momentum for this?
Yeah, I think there are different things that people can do. I think one thing is there's been a number of different templates, and I can send you one after this, different advocacy groups that are kind of getting stood up around this to help people write letters to their, with a press of the button, you can send a letter to your congressman or senator. In the TWIV interview at the end, I said, get in touch with me to help, but that was a bad idea. I've gotten too many. My inbox is is extraordinarily full every day now. So don't write to me probably, and I probably won't respond. If you do, I apologize. But what we can do is, I think after this, I'll send you a link. I think you could probably put the link on maybe down below the video or something,
Yeah.
or that people can click on, and this will be. There are different links that go to different advocacy sites, and some of them that are getting set up do allow they give some more information. We're building out animations. There's been kind of a whole army of people that are getting involved. And maybe in the link, if people want to get more involved with these groups rather than just sending a letter, there will be some contact information there. And there's a lot of momentum. It is, as a public health person and a researcher, there's few opportunities, I think, and as individuals out in society, I think we have few opportunities in life to truly change the course of an epidemic that's killing, potentially eventually millions of people on Earth, and continuing to infect and infect millions of people just in the United States here. And I think that there's an exciting groundswell of support, and I encourage people to get as involved as they can, because as much as you'd be supportive of helping to push vaccines through, if the government wasn't already pushing that very hard.
Yeah.
I think we should all be considering this with the same urgency that these things need to get pushed through as much as any vaccine. And it's just not as readily palatable by the politicians and everyone. And so I think the more support we can get, the better.
Well, speaking of vaccines, I know you've done a lot of research around vaccines. We'd love to have you back sometime to talk more about vaccines and also get an update on what's going on with COVID-19 testing. Hopefully, next time we chat with you, if we have that opportunity, we're in a much different place than we are now. And
I really hope so too.
But so I can say on behalf of all of our viewers and us here at MedCram, thanks so much for your work, Dr. Mina, and the leadership that you've shown with this. We really appreciate it. And any final words before I let you go?
No, just spread the word. I think Twitter actually turns out to be a really powerful tool to get people to recognize just how important these issues are, and Twitter and other platforms. So it's amazing. I just want everyone to recognize that every little bit is truly helping here to push the political will towards changing. And these are mountains that we're trying to move from a regulatory perspective, and it's working.
Yeah.
So I just want people to know that.
For people that want to follow you on Twitter, what is your Twitter name or handle, I guess it's called?
It's at Michael Mina _lab.
Okay.
So we can maybe put that in the description or something later.
Excellent. Well, thanks so much, Dr. Mina. I'll let you go and get back to your important research. And thanks again for joining us today.
Absolutely. Thank you.
And to everyone watching this, thanks again for tuning in. Thanks for all your comments, for all your questions over the past couple weeks. Like I said, we're going to do our best to follow up with Dr. Mina and see where things are in another couple weeks. And we appreciate all the support, and hope if you're inspired by his work like we are, that you'll get involved and consider reaching out to your elected officials and keep the momentum going for some improvements in COVID-19 testing that we really need. Thanks again, and we'll see you soon. Dr. Schwelt will be back from his vacation next week or by the end of this week, so we hope to get another update up soon, and we'll see you then.